acid we need so our body can make red blood cells. Causes poor nutrition or anorexia, malabsorption in the small bowel, boozing it up. That's what ETOH means if you didn't know it. ETOH means alcohol. Why? Because boozers don't eat right. They skip meals. Lost during dialysis. Easiest way to fix it, supplements, green leafy vegetables. Alright, microcytic anemia is straight up an iron deficiency. Number one cause, inadequate intake, translates out to shit diet. Not doing animal proteins. Okay? Animal protein, specifically red meat. Dark green leafy vegetables. Sometimes it's poor GI absorption. I might have something evil like Crohn's disease. We're going to talk about him next week. Blood loss. What are they going to look like when they're anemic? Any form of anemia. What are they going to look like?
Like pale skin.
They're going to be pale skin. What else?
Cold.
Maybe cool to the touch. What else?
Fatigue.
Huh? Fatigued? I love that. What else?
They bruise easily.
They could bruise easily. I once had a little old lady come in like cars on a train. All right, and everybody's carrying their hemoglobin or carrying their oxygen. Does that make sense?
Mm-hmm.
They're all carrying their oxygen just like they're supposed to. Problem is, this little grandma was missing 2/3 of her train. What little hemoglobin she had, it was working as hard as it could. She didn't have enough. Anybody want to guess what her lab value was? Her hemoglobin? What's that in relationship to the normal hemoglobin for a woman?
It's higher than mine.
Yeah, 10 points off. Besides labs. Their appearance, their fatigability, what does that mean? How easily they get tired? Okay, what else? Of breathing. Ease of breathing. Easiest interventions, diet and blood transfusions. The goals, what do I mean when I do this? Get us back to homeostasis. What causes blood loss? Interventions, the same thing. Sickle cell. Sickle cell anemia is a very specific type of anemia all unto itself. Alright, it is a genetic form of anemia. It likes to go after young African American males. I've seen a few female patients, but 90% of the time it's the boy type people. Anybody old enough to know what a sickle is? It's something that cuts grass. It's what we used to use to harvest wheat. It's a big long stick with a big iron moon on it. Okay? The red blood cells, instead of being all happy donuts, they start clumping together. And they are the wrong shape. That change in shape decreases their ability to carry oxygen. And when when they clump together, they occlude the bloodstream. Specifically distally, meaning my toes and my fingers, furthest away from the heart. Does that make sense?
You said they include the
Blood vessels,
blood vessels?
the distal blood vessels. So furthest away from my heart, legs and arms. The saddest thing I ever saw in my life was taking care of, and the tissue's not getting enough oxygen. Right?
Does that make them like cramp?
Huh?
Does that make
No,
them?
it's a sharp pain. Imagine, okay, when you were a kid, you ever played with the word precipitating factors?
What relieves it?
No,
Factors that happened before.
things that cause it to happen. Precipitating factor means trigger. Things that cause it, a sickle cell crisis to happen. A crisis is when they're having the active pain issues. So, things that cause a sickle cell crisis. I have a dear friend of mine who's a young African male. He lives in Phoenix. He keeps wanting to come out and visit me in Albuquerque. And I keep telling him, no, booger, if you want to visit, I have to come down and visit you. What did I just suggest? What do you think the trigger is I'm talking about? Altitude. Why? What happens when we go to a higher altitude? Less oxygen. Good. So changes in altitude. Right? He's like, but I want to come up to the tram. I'm like, are you crazy? I go up to the tram, I'm good for about 30 minutes, and all of a sudden I start getting altitude sickness. He goes up on that tram, he's going to go straight into a crisis. Okay? Altitude, I think I spelled it right, maybe? Maybe not. T-I? Yeah, I need more coffee. There we go. Infection, trauma. Every time he rode around on his 10-speed bike, I was terrified he was going to get in a wreck. And stress! I told him he had to go learn a martial art so he could center himself. And he did. He went out and started learning War Mango. Those are the triggers for a sickle cell crisis. That's when they have an issue. And all the symptoms come up. So, what type of interventions, now that you know the patho of a sickle cell crisis, what do you think would be the number 1, 2, and 3 interventions for this patient? Is his blood thick or thin?
Thick. It's thick.
It's thick. So what do I gotta do?
Fluids.
Fluids. High volume fluids. That makes sense? I'm gonna hyperoxygenate. But he's at 80, he's at 96. I don't care, I want him at 98. Hyperoxygenate what little cells he's got. And now he's crying like a 5-year-old. What should I give him? Pain meds, narcotics. I had a huge argument for a patient who has sickle cell anemia. Close.
What?
Close. How about stay away from the triggers? Stay away from the triggers. Because if I stay away from those, I can cruise with sickle cell, no problem. The last step on treating sickle cell is a blood transfusion. This is the reason why back in the early 80s, before most of you were learning how to walk, lots of folks were ending up with HIV. Because we weren't able to screen for HIV yet in the blood transfusion. Thrombocytopenia. Thrombocytopenia. 10-cent word means I ain't got enough platelets. So what am I at risk for? Yes, sir.
Sorry.
Which means a falsehood, lots of people believe it. Most folks who are chronic pain patients don't take pain medications to the point where they're unable to function. Most folks who are chronic pain patients, they want to go from an 8 or a 9, okay, down to a 5 or a 6. Does that make sense?
Yeah.
They don't want to get knocked out. They want to get functional. All right, here's a trick question for you. I'm a chronic pain patient. You want to take a guess at my number right now? Where I'm functioning at right now? This second? You're close, I'm an 8. Right now, this minute, I'm at an 8. And I've stayed there 90% of my life. I sure as heck can't teach. I just suck it up, buttercup, and go through it. Alright. Thrombocytopenia. I ain't got enough platelets. What causes it? Autoimmune diseases, overuse of heparin. This is one of the reasons why a patient on a heparin drip every single day, at least once a day, gets a CBC run. As part of a CBC, a complete blood count, is your red blood cells, your H&H, and your platelets. I would hate to be the nurse that didn't catch a patient trending into thrombocytopenia. You've got to look at the labs. Okay? Bone marrow suppression. What would cause bone marrow suppression? Cancer or somebody was saying it. Chemo. Chemo and radiation therapy.
Supposed to go around there.
Tells my bone marrows to quit working. Alright? Critical values, less than 50K, they're at risk for bleeding. Look at that one, less than 20. Spontaneous bleeding. That means they just happen. You ain't got enough to keep it from stopping, or stop it from happening. Less than 20, they can stroke out on you, ladies and gentlemen. A good reason to know your labs. Types of, I gotta update this slide. Types of blood products we love to give. Packed red blood cells. PRBCs. Alright, PRBCs. 3 ways. It says 2, there's actually 3. 1, I decide, get in a motor vehicle accident, I need emergency surgery. Ta-da! I end up over at the trauma center, they're hauling me into surgery, they realize I'm bleeding, they gotta give me some blood, they call United Blood Services, United Blood Services brings the blood to UNMH and they hold it and they have it ready for me. That is a blanket donor donation, and I don't know who gave it to me. Okay? That is just simple donor donation. The second one is called autologous. Auto, it means self. If I know it's time to finally get my knee done, as a total knee, that's a big surgery, I'm gonna lose some blood, chances are I may need a blood transfusion. I can go to United Blood Services or one of the other blood banks, and I can bank my own blood, because I'm A negative. Only 10 to 15% of the United States are A negative. Alright, so I would, in an absolute plan of care, bank my own blood before I went and had a major surgery. Does that make sense? That's autologous donations. that's not on the slide is a directed donation. I have a dear friend of mine, she's one of my adopted daughters, in Phoenix. When she gave birth to my would-be grandson, she tried to bleed to death after the delivery. I know for a fact that Laurel's blood type is the same as mine, A negative. There's like 6 of us that all hang out together, they all know our blood type. And when she started trying to bleed to death and was getting sent to emergency ICU, man, I was on the phone calling my buddies, hey, we need some egg right now. And we all ran to one of the blood services and said, Captain, here's the medical record number for the chick that needs it, here's the name of the hospital, send it.
So you could pick who you want your blood?
It was directed because it was emergent. It was directed because it was emergent, okay? You can do a directed blood donation. And we saved her, us and about a handful of other people, because she had, any of you guys ever work on your car? As a transfusion, platelets, I wish I had a color yellow, well, a little bit lighter yellow than my jacket, my shirt I'm wearing. All right, a little bit brighter yellow. Not quite this. Not quite that. A little bit duller than that, but they're yellow. When they come up from the blood bank, you gotta keep the bag moving. Cause they like to stick. Fresh frozen plasma is plasma that's been spun off. Any of you guys ever given plasma?
I don't know. I've been very tired.
Me too, and I've tried to donate and now they can't hit me. My veins are so shot. Cause I've given blood so much. I've got my 5-gallon pin for directed blood. And then we can also infuse albumin. Comes in a little glass jar. It's pure protein. Costs about $22K a jar. Very expensive. Don't mess up that infusion. When we transfuse whole blood, packed red blood cells, there's usually, and you're gonna wanna write this down, 250 milliliters per unit of blood.
Is that what time?
Hmm?
Is that what time?
There's usually 250 milliliters per unit of blood. No, when we give it. When we give it.
That's in the pack.
Yep, PRBCs. So, I wish I could turn that off because I want to know. Pre-transfusion. How do I know when a patient needs a transfusion besides sickle cell crisis? How do I know? Labs. What's the magic number? Any of my techs in here know it?
For what?
What's the lab I've gotta have on a hemoglobin before I'll transfuse the patient?
12 to 18.
No, for transfusion.
Oh.
That points that they need a transfusion.
I don't know. I just go run and get the blood from the blood bank. I can tell
Okay,
you
so
that
we're gonna
process.
pick your brain when we get to that step.
7?
The magic number. Less than or equal to 7, or symptomatic. So if I'm at 7.6 and I'm huffing and puffing and I'm severely fatigued, chances are I'm still gonna get a transfusion. Alright? Hey Jason. You need to know, number one, is it appropriate that this patient gets a blood transfusion? You need to verify that Dr. So-and-so did indeed give 2 units packed red blood cells today. Okay? And you need, as a registered nurse, you better make doggone sure that consent is signed. This is an invasive procedure. Oh, but it's only going through their IV. Dude, this can kill them. Okay? I've probably transfused, well, just me. alright? You've gotta have that consent sign, okay? You better stick where it says 20 gauge IV catheter, 20 gauge IV catheter times dose, times 2. There's another slide I gotta update. The reason is, can I put it through a 22 in the back of the hand? Why? Why? What's gonna happen? No, it's not gonna happen. It's gonna hemolyze the blood. What's that 10-cent word mean?
It's gonna destroy the cells.
Yeah, it's gonna pull those cells apart. Why would I transfuse blood just to break it apart while I'm trying to get it into the person? Does that make sense? You put one here, you put one here. When I used to teach IVs to the students, I said, okay, you can start IV here, you can start IV here, but you leave these alone. Yes, I know they're the easiest ones to get. You leave these alone because these are for emergencies. This is for blood transfusion. Okay? Because they're the big guys. They'll handle a 20 gauge or an 18 gauge. Biggest one I ever stuck in somebody was a 16 gauge. It was a garden hose. Alright? Why do I have 2 IVs? Because when blood comes from the blood bank, I got the order, I got the slip, I got the call from the lab that says, blood's ready. I go, okay, tech, please go get it for me. She goes hoofing down there and verifies the piece of paper matches what the blood bank kid has, right?
Yes, and then they have us read like all these numbers off the bag, front and back, this is the blood type, who it's for, the MRN number of the patient.
What else do they do?
Oh,
What else do they do?
You have to identify like the blood type, that the bag is the same as what they're ordered.
expiration date.
It's also the MRN number, that it's the correct patient.
Now, when you pick up the blood, I'm gonna pick on you for a second.
You're
okay?
fine.
When you pick up the blood, do you go, okay, here's your blood, Jamie?
No.
What do you do?
I have to go to the nurse and make sure they get it. There's actually another slip of paper we have to fill out. I have to put, who I was getting the blood for, who I got it from, the person in the lab.
And
You have to
who gave it
sign
to you?
who I gave it to, yeah.
Ladies and gentlemen, I want you to consider handling a unit of blood with the same importance as you do handling narcotics. Okay? The same, you don't just set it on the counter. Okay, I'm going to lunch, bye. Bullshit. Alright, it's got the same importance as having a narcotic in your hand. The reason is, and I'm gonna get to those 2 IVs in just 1 second. When blood leaves the blood bank, and you're bringing it upstairs to your nurse, okay, or down to ER or OR, I don't care. You have 4 hours after it's left the blood bank to get it into that patient's body. 4 hours.
Oh, that's an ICU, right? ICU, they get.
Now, what's gonna happen if I've only got 120 gauge here, and I've got the blood infusing, and this IV blows? Now what do I gotta do?
Another one.
I gotta do an emergent IV start.
That's why you should always have 2 anyway.
If this one blows, flush this one, move it over, plug it in, ta-da, problem solved. The nurse, now when we start an IV infusion, if I'm gonna give 250 milliliters of fluid, and I get a little hyper excited, oh, I wanna get this done, I wanna get this done, I wanna get this done. And I run it in at 250 milliliters per hour.
No, you have to do it slow,
Why?
in case the patient's having a reaction, so you're not gonna see it.
Or, what if they've got CHF? That's going too fast, what are they gonna show me symptoms of? Who said it? Fluid overload. They start showing symptoms of fluid overload, write this down. You slow the rate of the infusion, And now, because I have a second IV, I can call the doctor and ask for what type of drug. What classification of drug am I gonna give to treat fluid overload? Diuretics! Winner, winner, chicken dinner, you got it. But you can't combine, you can't have a blood infusion going on and then push Lasix into blood. You gotta have a second spot. Or, like you said, they have a major reaction, now I gotta really push some big drugs. Okay? So, symptoms of fluid overload, turn the rate down, get a diuretic. Okay? So we got the blood from the blood bank, we verify the order, we double check everything and compatibility. Can you guys see this? Here's the unit of blood. Stop dropping it. I'm so old, I remember when blood came in glass. Glass bottles. Can you guys see the tubing? Can you guys see the Y? You see the Y? That's Y tubing. You have to use Y tubing. Why? Because blood will clog up if you don't prime it with normal saline. The only thing forever and a day you ever prime blood tubing with is normal saline. I promise you that's an NCLEX question. Okay? Normal saline. Yeah, you think? If I say it 5 and 6 times, you better know it. You guys see where the drip chamber is? This tubing does not go on this pump. I don't know why I use this pump, but I just grabbed it. This is where you would literally count the drops per minute. Okay? I'm so old. This was a glass jar. We never could use a pump. I got so excited when they made tubing that went on pumps. It made my life so much easier. But you had to count the drops per minute to make sure you had the right weight. Okay? Okay. Steps. The blood came up. My tech brought me my blood. I go in. I make sure my patient has what? 2 IVs, right? I flush both of them. Are they both working? Life is good. Yay! I got a consent. I got an order. They need the blood. They're symptomatic. Their hemoglobin 6.5. Time to give blood. Yes? I go get a set of vitals. Did I say my tech gets me a set of vitals?
No.
I said I get a set of vitals. The RN. And then I need a second RN. Do not find a doctor, do not find a PA, do not find an LPN or a CNA. This is a 2 RN jobber. And then we do the same. This is the blood bank number for that particular unit. Okay, you have to document the number. I just snagged one of the stickers off the back. Because it's hanging up in the patient's room. I just keep it with me so I know that's unit number 1. Does that make sense? Yes? You wait till the product gets to the patient. Then you start your timing. I had a nurse decide she was gonna start, it was all the way up here. She was gonna start her 15-minute count. I said, no, take another set of vitals. Now, before I hang blood on a patient, I love to ask them, have you ever had a blood transfusion before? And if they say yes, I go, have you ever had any kind of a blood transfusion?